Comment ça va, Philippe?
Ça va, Kherdine? Kherdine, je vais te contacter dans pas longtemps pour te demander quelque chose d'important. Tu vas bien?
Charles va bien? Très bien. Et vous, Charles, tout va bien? Monsieur Sandou?
Oui, merci. Content de vous voir.
Coucou à tous.
Coucou à tous.
Moi aussi.
Ça va, Kherdine?
Ça fait longtemps.
Je vais te contacter dans longtemps pour te demander quelque chose d'important. Tu vas bien?
Charles va bien? Très bien. Et vous, Charles, tout va bien? Monsieur Sandou? D'accord. Ça marche. Coucou à tous.
Oui.
Coucou à tous.
Coucou.
Monsieur Abdenbi,
Oui,
vous voulez qu'on commence maintenant? Il est 15h02 là.
eh bien, oui, on peut commencer, je pense, avec l'accord de tout le monde, des conférenciers surtout. On commence?
On commence.
D'accord. Nabila, tu vérifies s'il te plaît?
Oui, oui, c'est bon. On peut commencer, il n'y a pas de problème.
D'accord. Okay. Good afternoon and maybe good morning in some countries and good evening in others. It's a great honor and a pleasure for the Algerian Society to organize with the stereotactic and functional surgery WFNS committee this webinar about trigeminal neuralgia. And I want also, most of all, to thank all the speakers, the prestigious speakers of today, who are Professor Sandou, Professor Cornu, Professor Valérie, Professor Abdenbi, and Professor Gennen. They will give us new updates about this disease, the trigeminal neuralgia, and I'm sure that it will be benefit for all of us, young and less young. So I will give, without lasting the talk to Professor Abdenbi, but I just want to say a few words. Of course, I will not say all what I can to say about Professor Abdenbi, but many of you know him. He is professor of neurosurgery at the University of Medicine in University Algiers 1. He was head of department of the specialized hospital Selim Zmirli, and he had at this time a referent department in functional neurosurgery with all the fields of functional neurosurgery, of course, trigeminal neuralgia, Parkinson's disease, movement disorders, and spasticity. So he's also past president of Pan-Arab Society, past president of the Algerian Society. He is currently member of the World Academy of Neurosurgeons, and he has contributed to several chapters and write many, many publications. So thank you, Professor Abdenbi, for having accepting to organize this webinar, and the talk is to you. Thank you.
Professor Barty, good afternoon, the president of the Algerian Neurosurgical Society. And I would like to thank you so much for the 11th webinar. President, Professor Cornu, President of the Stereotactic and Functional Neurosurgery Committee of the WFNS, and President of the French-speaking Neurosurgical Society, Professor Sandhu, co-chairman of the Stereotactic and Functional Neurosurgery of the WFNS, and Professor Charles Valéry, head of Department of Gamma Knife in Pitié-Salpêtrière Hospital, Professor Ghanan Lakhdar, neurosurgeon at the Salim Zmirli Hospital. Dear colleagues, good afternoon. It's really a great pleasure to be with you, to be together, and to share our knowledge in the neurosurgical treatment of trigeminal neuralgia. But before getting into our topics, I want to remind you of some clinical features and differential diagnosis of trigeminal neuralgia. Dr. Tyrell, how to do to partager l'écran?
Partagez l'écran en bas. You have to share the screen.
Yeah. Okay. Some words about the anatomy and the physiology, as you know.
Monsieur Abdenbi, c'est pas passé.
Comment?
Ce n'est pas passé. Partagez l'écran en bas. Vous appuyez sur le bouton vert. En bas de l'écran, il y a un bouton. Voilà, très bien. Vous sélectionnez votre document. Très bien. Plein écran. Très bien.
I said that somatic afferent fibers consist in 3 neurons that transmit pain, light touch, and temperature sensation. The first neuron from the skin receptors to the spinal trigeminal nucleus with the body cell in the gastric ganglion. The second neuron from the spinal trigeminal nucleus to the ventroposteromedian nucleus thalamic, and finally the third neuron from this nucleus to the sensory cortex. The gastric ganglion, what are its anatomical relationships? Superiorly with the inferior surface of the temporal lobe, here. Inferiorly, the greater petrosal nerve, the motor trigeminal root, and the foramen lacerum. Here, the foramen lacerum. Posteriorly, the brainstem. Laterally, the middle meningeal artery here. And medially are the posterior part of the cavernous sinus and the internal carotid artery. What's the physiopathology? In a few words, the current opinion is in favor of a neurovascular conflict, demyelination of primary sensory trigeminal afferents in the root entry zone. It's a transition zone between central myelin and peripheral myelin. The disease, trigeminal neuralgia, is known as one of the most painful complaints of the human kind. It's also called tic douloureux or suicide disease. And the current definition is a disorder characterized by recurrent unilateral brief electric shock-like pain, abrupt in onset and termination, limited to the distribution of one territory or more of the trigeminal nerve and triggered by innocuous stimuli. The carbamazepine is the drug of choice. Other anticonvulsive medications as amitriptyline, lamotrigine are also efficacious for this pain. The pain, in order to assert a rigorous history and rigorous also clinical examination, it's well known that the pain in trigeminal neuralgia is compared to a flash electric current. The territory is one distribution alone or in combination with another of the trigeminal nerve. The duration, few minutes, and what is important is the negative clinical examination. All this, the symptoms leading to bad quality of life with isolation, depression, and sometimes leading to weight loss. The MRI is asked to exclude a tumor of the PC angle or the Meckel curve. What are the other headaches or facial pain? The migraine with nausea and vomiting, duration 1 to 3 days, cluster headaches with a runny nose, a watery eye, and a drooping eyelid, the temporal arteritis with the inflamed temporal artery, fever, loss of vision, the postherpetic zoster neuralgia, the occipital neuralgia with frontal irradiation, and finally the temporomandibular joint pain. After all this, who and when to operate? All of you know that the good response to carbamazepine is obtained in approximately 70 to 80% of the patients. And it's observed a honeymoon during few years. After that, the remaining patients will be or can be refractory to carbamazepine or presented severe side effects. As you know on this slide, unsteady sensation when standing, or allergic skin reactions and somnolence, or gingival overgrowth. We have to not answer or not to say yes for these patients with excellent to satisfactory pain relief with medication, but they prefer to have surgery in order to avoid these medications. How to operate? Essential refractory trigeminal neuralgia can be treated by one of these 5 modalities: microvascular decompression, the percutaneous procedures, which include balloon compression, thermocoagulation rhizotomy, glycerol-rhizotomy, and finally, the gamma knife treatment. Percutaneous procedures include, as I said, radiofrequency rhizotomy, which is a thermal process, the balloon compression, a mechanical method, the glycerol-rhizotomy, a chemical process. the target of this procedure is the junction of, between the junction of the Gasserian ganglion and the TP or triangular plexus. Microvascular decompression and open surgery, the target of the surgery is the root, the trigeminal nerve root near the entry zone of this nerve. And finally, the gamma knife radiation. I finish, and now, Professor Sandhu, you are invited to tell us, to talk about the imaging, from the imaging to the open surgery of refractory trigeminal neuralgia. And thank you. Professor Sandhu was the chief of department of neurosurgery in the neurologic and neurosurgical hospital Pierre Vertemer in Lyon. He was previously the president of the French-speaking Neurosurgical Society. He was also, he organized in 1997 the World Congress of Stereotactic and Functional Neurosurgery in Lyon, and currently he is the co-chairman of the Functional and Stereotactic, Functional Neurosurgery and Stereotactic Committee of the WFNS. He has many books, he wrote many books, hundreds of publications, and many lectures, hundreds of lectures and seminars and conferences worldwide. Professor Sandhu, thank you. You can hear me? Yeah. So thank you very much for your very nice presentation. You know my CV better than me. And I am very proud to be invited by your society to participate in your webinar. I have so many colleagues and friends in your country, and I am very happy to collaborate with you, and you are a very good friend. I propose to join my two presentations in the same presentation. So I will develop on the first part from imaging to surgery and MVD at same presentation. Okay. Le diaporama, attends, non, là. Là, tu vois. Okay. Could you see what I present, and you can hear me? Yes. Yes. Okay. Thank you very much. There are two parts, from imaging to surgery, and second part is on MVD, entitled "Not all patients should have MVD surgery." Of course, MVD surgery is the first option, but not all patients can respond to this surgery. Recently, it appeared in the neurological journal Neurology, a new classification by Kruku and co-workers. I was invited as a neurosurgeon to participate in the new classification. Classification is secondary trigeminal neuralgia, idiopathic neuralgia when imaging does not show anything clear, and the classical trigeminal neuralgia,
which by definition requires demonstration of morphological changes in the trigeminal nerve root, mainly from vascular compression. There is a big dilemma. Of course, microvascular decompression is a gold standard, but not all primary trigeminal neuralgia have neurovascular conflict. According to publication, 5 to 30% of patients with clear trigeminal neuralgia do not have neurovascular conflict. Second, 40% of patients with trigeminal neuralgia have bilateral neurovascular images. I don't say conflict, images, more or less symmetrical. That means that an image is not synonymous of conflict. Third, some patients with properly done MVD are not cured or have recurrence. And there are two key publications pointing that. Adams a long time ago in Oxford and Kimberkiel recently in USA. This is very important. We have to select patients according to anatomical imaging and because there are alternative methods to microvascular decompression. You know, surgical option, Professor Abdenebi described, and not only MVD. Is MRI able to reliably detect neurovascular compression? In a personal study with my team, we could demonstrate that we can predict neurovascular compression by using high-resolution MRI combining 3 sequences, T2 high-resolution, TOF angio, and 3D T1 with gadolinium. I insist on asking for the 3 sequences. T2 show fine anatomy of vessel and nerve in the cistern. TOF angio with presaturation filter show arteries, not veins. And T1 with GADO show artery and veins. So by combining the 3, we can predict vascular compression. This is an example here. On left side, you see a cross compression between root and superior cerebellar artery. With TOF angio, you can affirm it is an artery. And T1 with GADO does not show anything more. So there will not be vein additional to artery. And this is the corresponding surgical images. On left side, you see superior cerebellar artery compressing the nerve. And this is decompression by transposing superior cerebellar artery, preserving the veins, if we can preserve better, to avoid cerebellar hemorrhagic infarct. And we maintain a superior cerebellar artery by Teflon piece. Nothing touches the nerve. This is important. Nothing compressing the nerve. This is a classical example. I want to insist on the vein. We can have in almost 10% of patients a venous compression. You see T2 high resolution, you see the root, small cistern, and here vessels. We cannot say it is artery or vein. With TOF angio, nothing. This is not an artery. And with T1 with GADO, you see the vein. And these are the corresponding surgical images. You see the root on right side. You see here vein cross-compressing here, which is a transverse spontaneous vein described by Matsushima in Japan. And treatment is coagulation of the vein, cutting to liberate the root. This is a pure venous compression. I want to insist on that. In 2002, we revised our cases, around 500 at that time, and we could find retrospectively after operating reports consulted that there were a gestat pontine in the so-called trigeminal root entry zone in 52% of patients. The conflict was in the mid-third cisternal region, not in the trace, in 54, and juxtapetrous, very much far from the trace, in 9.8%. So we have to expose the root from brainstem to porus of Meckel cave, and not only at trace, to explore the root. And this is more than 100%. Why? Because we found multiple conflict in 37% of patients. So if you find a conflict, you must search from additional conflict and treat all the potential conflicts. And I insist on the location at porus of Meckel cave in 9%. And this is an example, very interesting. Root on left side, compressive vein at exit of porus of Meckel cave, and you see after dissection of arachnoid, this grayish aspect, which is demyelination of the nerve, not at trace, but in the juxtaporus region, pure venous conflict. 10%, around 10%. Now, an important study. We compared outcome with Kaplan-Meier study up to 16 years of follow-up. We compare outcome according to grade of compression. Grade 3 is big compression and grooving in the nerve, indentation by the vessel, and long-term probability of long-term cure is 85% at 16 years. Grade 2 is displacement of the root, and cured is 75%. When grade 1, which means only contact, long-term cure is 65%, with a P very highly significant. This means that grade 1, because 35% of failure on long-term is not probably the alone factor, not probably the only one factor. So we must take into account of this when indication of surgery. Is it possible to predict the grade on MRI? You have here grade 1, 65, grade 2, 73, grade 3, 85 cured on long term. We did a blinded study retrospectively. Neurosurgeon who studied the imaging was blinded from all the data, and he even did not know about the side of the neuralgia. When the grade was 3, you see, we could make a correct grading in this part, this percentage, and we underestimated grade 3 in most patients. This means that in grade 3, we cannot miss a high compressive conflict by studying imaging. Grade 2, you see, this is overestimation. And grade 1, we overestimated the degree of compression in many patients. So it is difficult to predict the role of the vascular relation with the root in grade 1. How to improve reliability to detect the grade of compression, especially in grade 1? We did this study with high resolution MRI, and we show that there was atrophy of the root at the level of the compression by studying the cross-section area in ipsilateral side atrophy was more important than the contralateral in same patient or the control group. So we have to study the diameter of the root at the level of the compression. We could also ask for diffusion tensor imaging. This could be especially important in grade 1 to know if there is a real compression or not. There is a modification, decrease in fraction of anisotropy here on the side of trigeminal neuralgia compared to contralateral side and group control. And apparent diffusion of coefficient, which means damage and suffering of the nerve. This is significantly different on ipsilateral side compared to contralateral and control. So this means that in grade 1, when we are not sure of the role of the vessel, we could ask for DTI and study the diameter of the nerve. Ask that to imaging people. So not all patients should have microvascular decompression. There are other offers for lesioning method. We did, for this meeting, meta-analysis with a colleague here in Lyon. And we analyzed 7 studies, regrouping 4,500 patients with a follow-up of 3 to 10, and late relief with radiofrequency thermoisotomy in literature was between 26 and 82%. And this was correlated with a degree of hypoesthesia. This is very important. And this is an older slide. I reviewed my patients, and we had only 7% of long-term recurrence, which is very low, compared to Campolat, which is a champion in Europe, and Sweets, the world champion. And this is not because we were better than my master Sweet or my colleague Campolat. This is because I deliberately created hypoesthesia. So if we want long-term result with thermoisotomy, we have to obtain hypoesthesia, which is disabling. Balloon compression, we review literature, and you see here the mean long-term outcome for cure. We did that for glycerol gangliolysis, and we did that for radiosurgery, and mean is 56%. I will not comment on that because other presenter will develop that. And for MVD, 84% in literature. So what is, according to all this experience, literature and personal experience, our decision-making process? Patient with not too aged, good general condition, taking into account patient preference, with a clear-cut evidence of a neurovascular conflict on imaging, I mean grade 3 or 2 on imaging, we push the patient to go to MVD. On the contrary, when no vascular conflict or very mild, we push to percutaneous lesioning or radiosurgery. Grade 1 is difficult to decide. It will depend upon preference of patient, age of patient. I have no personal preference for that. We could push on one side or the other side. When we decide for a lesioning technique or stereotactic radiosurgery, I came to the conclusion that when pain territory was mainly V1, V2, better, in my opinion, to go to balloon, because with balloon, we have less corneal anesthesia, less side effects. And when patient has V2, V3, we push, in our experience, to go to thermoisotomy, which has more long-term efficacy provided we create hypoesthesia. For radiosurgery, I have no experience. No doubt that there is an increasing number of patients benefiting from radiosurgery in the world. As far as we are concerned, we do not know exactly what should be its precise price, as a first option or a secondary course. I am not an expert on that. I have nothing against that. Now I move to the second part of my presentation, microvascular decompression. Everybody listening to this lecture knows that. We think important that MVD should concern the entire route, check for eventually several conflicting vessels, take into account the potentially compressive vein, and free the route from all arachnoid adhesion. Concern the entire route because there are not only conflicts at tres, but also cisternal and juxtapetrous. I insist on that. Then we have to check for several conflicting vessels. This is an example of the trigeminal nerve, cross-compressed upper by superior cerebellar artery and lower by AICA. This is after dissection of arachnoid. Two arteries. There is also veins in combination to arteries. This is on the right side. You see a compression of the root by superior cerebellar artery, pushing downward, and this pontine vein, branch of the superior petrosal vein. And you see after dissection, then grooving by the vein with a grayish aspect of demyelination. People who don't believe can see this slide to be convinced. So it's addition of artery and veins. Then we have to take into account of compressing venous conflict. This is root. This is a transverse pontine vein, cross-compressing. We have to dissect and to coagulate and cut. Pure vein. And we have to free the root from all arachnoid adhesion. You see the adhesion here. One case, and the other case, strong arachnoid thickening. Then microvascular decompression should not be traumatic, of course, otherwise it is a destructive procedure and not compressive. We reviewed our series comparing patients with neocompression, which means interposition of foreign body, or transposition. You see, when patient had only transposition, no compression. Long term, at 60 years, Kaplan-Meier study, 84% cured. With interposition, only 63%. So transposition better than interposition. This is an example for superior cerebral artery, you see here. This is a way to avoid neocompression. We are against pushing balls of material here, neocompressing the root. And this is for AICA. Examples. How to minimize complication. This is our overall morbid mortality. Mortality rate 0.3 at that time. Too much, due to infarct of cerebellum by manipulation of arteries or veins. Neurological sequelae, gait disturbances 0.3, trochlear nerve palsy 0.6, facial nerve palsy 0.6, hearing decrease 2.2, trigeminal sensory disturbances 3%. This is an aggressive surgery. So how to minimize complication? We have to use infratentorial supracerebellar approach to avoid stretching of the eighth nerve. You see, you have to turn the craniotomy not here, but just below the transverse sinus. To approach under tentorium by opening arachnoid, this is the fourth nerve, and the two branches of the superior cerebral artery, and this is after decompression. We keep the veins as much as possible to avoid infarct. This is artery transposed, maintained here by Teflon sling, and root totally decompressed without neocompression by infratentorial supracerebellar. And we have to respect as much as possible the superior petrosal venous system. You see here, superior petrosal vein with the three afferents, pontine, cerebellar, mesencéphalic. If we coagulate that, there is a risk of 3 to 5% of cerebellar infarct. And you see an example coming from our hands, my hands as a surgeon, of infarct due to venous destruction. And conclusion, MVD is able to get good relief in grade 3 and 2, on average 80%, and stable, you see, stability a long time, not curve like that. And this can alleviate pain not only in typical trigeminal neuralgia, which correspond to paroxysmal pain, but also to atypical trigeminal neuralgia, which combine paroxysmal and permanent. And we can get good relief on permanent after a long follow-up. And this is compared to the Janeta.
The conventional program. He told you, we start from bottom, we go up. This is the omnidirectional mode.
You hear me? Yes?
Yeah, you can follow. You go ahead, Professor Sandhu.
Yes, I have a 4-minute video.
Yes, il n'y a pas de problème.
C'est bon?
Oui, c'est bon, c'est bon. Vous pouvez y aller.
Voilà. This is demonstration of a typical case. On left side by superior cerebellar artery. This is keyhole surgery, but we must make a sufficiently wide craniotomy to explore all the route from brainstem to porus of Meckel cave and to manipulate the instrument. Sometimes we are snobbish. I mean, we want to have very little craniotomy. It is not a good idea. Keyhole, but not too small. I try to preserve the veins. The veins are preserved. This is the root. Superior cerebral artery, grade 2 of compression. We have to cut and disrupt all arachnoid adhesions, and we transpose upward the superior cerebral artery and the 2 branches, and we maintain a part using a Teflon sling. We must to avoid kinking, and we secure transposition by a hard piece of Teflon, and nothing touches the nerve, and then papaverine for avoiding spasm due to manipulation. And the last case is ICA. You see ICA from below, opening of arachnoid. This is infratentorial supracerebellar, but for ICA, we have to go a little bit laterally. 8th nerve, 5th nerve, ICA loop, making a groove in the inferior aspect of the root. We keep intact the superior petrosal vein. It is better to coagulate the vein than to avulse and have hemorrhage. But if you can keep the vein intact, you see the engrooving? Engrooving, this is grade 3. Engrooving in the nerve, here. And then we have to manipulate gently. AICA is perforator to brainstem, so you have to take care not to avulse perforators to brainstem. We use these Teflon fibers sling. we ask the scrub nurse to do that. Not so easy. Participation of the team is very important. Good nurse, good assistant. And I attach to the vein, not to have nothing to change the route. And I think this is the last picture. Okay, papaverine. And I think this is all. Thank you very much for your attention. Hello? No.
Yes, thank you.
Professor Abdenbi.
Thank you, Professor Sandou, for this excellent presentation, excellent illustration. And I think you will have many questions at the end of the webinar. You hear me?
Yes.
Professor Barty?
Yes.
Professor Barty?
Yes, Professor Abdenbi. Yes.
Yeah.
We can continue. The questions will be at the end. So we move to the next speaker, Professor Abdenbi.
Moment.
Yeah.
Partager l'écran. Où est mon PowerPoint? PowerPoint.
Monsieur Abdenbi, vous avez un souci? Je ne peux pas entendre. On n'entend rien, monsieur Abdenbi.
Est-ce que vous m'entendez là?
Maintenant, oui.
Oui, mais vous n'avez pas l'image.
Non. Il faut sélectionner la présentation. Quand vous mettez partager l'écran, vous sélectionnez.
Vous l'avez là?
Non. Il faut cliquer dessus et mettre partager. Quand vous mettez...
cliquer. De temps en temps, ça ne passe pas.
Je clique sur partager.
Oui.
Et je vais vers la
présentation. Vous cliquez et vous remettez partager encore. Vous allez avoir une icône partagée en rouge.
non. Partager.
C'est bon.
Voilà.
Ah, là, vous avez le...
Oui.
Thank you. I will talk now about the balloon compression of the gastric ganglion as treatment of the trigeminal neuralgia. The foramen ovale, one of the foramen of the skull base, is one of the anatomical cornerstone of the skull base, and you see it here with the other neighboring foramina, the emissary sphenoidal foramen anteriorly, posteriorly the canalis sinumatus and the foramen spinosum. The emissary vein, mandibular nerve, accessory meningeal artery, and the lesser petrosal nerve cross this foramen ovale. What are the aims of the treatment? Obviously, it's the analgesia, but preference without anesthesia, and the lowest morbidity. However, you should know that the corollary of good long-term analgesia is hemifacial hypoesthesia. This is the area of the compression of the balloon. The three branches, the ophthalmic branch, maxillary branch, mandibular branch, the gastric ganglion, semilunar shape, and the triangular plexus. For the gastric ganglion, 15 to 18 millimeters, and for the pars triangular plexus, 11 millimeter, and here the root before the brain stem. The operative room, essentially, you see here on the left the C-arm fluoroscope. What you need, the Fogarty French catheter, the metallic introducer with the Teflon catheter and the contrast medium. Here, the introducer, metallic introducer, the Teflon catheter, and the Fogarty catheter. And you can see on this slide that the balloon is beyond, with this black landmark, the balloon, this part, this end of the catheter is beyond the extremity of the Teflon catheter. Surgery was performed under brief general anesthesia with intratracheal intubation. The patient is in supine position, the neck and thorax slightly flexed, with the nose in a top position. Here we have from the skin puncture to the foramen ovale, we will cross the muscles of the cheek. You can see them on this left slide. On the right side, the pterygomaxillar fossa with its muscles. The Hartel techniques is defined by these three landmarks. The first landmark corresponding to the skin puncture is localized 2.5 centimeters laterally to the labial commissure. The second is on the zygomatic arch, the inferior ridge, 3.5 centimeters from the external meatus, and the third landmark is on the line joining the first landmark and the pupil. At the occasion of the skin puncture and crossing the cheek, the index of the neurosurgeon is in close contact with the internal side of the cheek. It guided the introducer in order to avoid the penetration of the introducer in the oral cavity. Here, when we observed a contraction of the masseter muscles, and for the anesthetist observed also bradycardia, this means that we have crossed the foramen ovale. And we have not to push the metallic introducer more ahead in order to have, in order to haven't metallic material inside the skull. You can see here the sella turcica, and here the clivus, here the petrous bone, the superior ridge of the petrous bone, and the tip of the metallic introducer is at the foramen ovale. The crucial step was the engagement of the foramen ovale, as I said, recognizable by seeing and feeling in your fingers the masseter muscle shrinking. The advancement of the metallic introducer was interrupted from that moment in order to avoid its penetration inside the skull. Here, the different shapes, possible shapes, septa, and ligaments. And as you can see, the shapes can be oval, crescent, cordate, round, almond, or elongated is here on the right. Also, some explanation for the impossibility to cross the foramen ovale, this wide spine extending, in this case, from the greater wing of sphenoid, and the spine covered also, or covers also, the foramen ovale. Here, another case which can be with difficulty to cross the foramen ovale. It's an explanation for the impossibility. You can see this long spine extending from the greater wing of the sphenoid. In these cases, some neurosurgeons in the world use intraoperative CT scan with neuronavigation to reach exactly the foramen ovale. Trigeminal reflex bradycardia and hypotension may happen when crossing the foramen ovale. Trigeminocardiac reflex or sinus arrest, some cases described in the word, occurred when the metallic introducer crosses the foramen ovale. the heart rate rapidly returned to normal after administration of atropine. The anesthesiologist of the team must be aware of this sudden physiological response. Here, one of our patients, and you can see the heart rate, the frequency at 63 before crossing the foramen ovale, 25 when crossing the foramen ovale, and after administration of atropine, the heart rate at 68. Is the CSF scape mandatory to confirm the good location of the extremity or the tip of the introducer? It was observed when the metallic catheter was pushed ahead the foramen ovale. Look here, we will have some drops of CSF after drawing out the metallic introducer. We remove the metallic introducer, pushing inside the Teflon catheter, and here the Fogarty catheter, the French Fogarty with this landmark, and in all patients approximatively the balloon will be outside the extremity of the Teflon when this landmark will be at the external extremity of the Teflon catheter. The Fogarty catheter's balloon was filled with contrast medium, and you can see here some air, and we have to evacuate this air to see a good shape and a good image on the skull X-ray. In this slide, you can see no metallic introducer, only the Teflon and inside the Fogarty catheters. Some drops of CSF mixed to blood. The landmark we introduce and we stop 1 centimeter after the black landmark, and we take an image. Here you can see, as I said previously, the gastric ganglion and the plexus triangular on a lateral view are after and before the line of the clivus. This is a right image, this is a left image, this is the sella turcica and a balloon before and after, with a pear shape. What is asked? The parameters of the balloon are in our technique, volume 0.7 cc, the duration 6 minutes, the location Gasserian and triangular plexus, and the shape pear. Here, some images, not recommended, cylindrical, and see the absence of the metallic catheter, only the contrast medium inside the Teflon, as I said previously. No metallic introducer, only the contrast medium inside the Teflon. A B-sac shape, also not recommended, and the result can be not satisfactory or excellent after awaking the patient. Some bad directions toward the posterior foramina or toward the orbitary superior fissure, and fortunately there was not bad outcome in this patient despite this bad location. Results: misdiagnosis in 1 or 2%. Impossibility to cross the foramen oval in 2 to 3%. Immediate pain relief the first day, the first postoperative day, in 96%, and in the long-term follow-up, excellent to satisfactory results, pain relief satisfactory with 1 or 2 tablets of carbamazepine in 2/3 of our series. And the recurrences were observed in nearly 32%, 1/3 of the series. Morbidity includes cheek hematoma, hypoesthesia, masseter muscle weakness, transient herpes labialis simplex, hearing impairment sometimes, transient nerve pulses, exceptionally, anesthesia dolorosa, exceptionally due to severe compression of the gaster ganglion plexus triangular. Exceptional vascular complications were reported in the literature as external carotid arterious venous malformation or internal carotid arterious venous malformation, subarachnoid hemorrhage, and temporal hematoma. Nerve pulses also exceptional, usually transient, and reported in some papers. After that, I tell you, merci, thank you, and now I call Professor Gannan, Lakhdar Gannan, professor in the Department of Neurosurgery of Salim Zmili Hospital. He was a colleague, collaborator in all my work during these long years. Professor Gannan, à vous la parole.
Okay. Terilt. Okay.
Non, c'est bon. It's okay.
Okay.
It works.
Okay, thank you. Good afternoon, everybody. First of all, I would like to thank my master, Professor Abdenbi, Professor Sendou, and of course, Professor Philippe Colnu, President of the French Language Neurosurgery Society. And finally, my friend, Professor Souad Bakhti, President of the Algérienne Neurosurgery Society, to invite me to attend and participate in this webinar on the treatment of the trigeminal neuralgia. The first treatment is the medical treatment of the trigeminal neuralgia. After is the surgical treatment, ballonic compression, thermoresotomy, glycerol injection, radiosurgery, peripheral neurotomy, and finally microvascular decompression. Choosing the treatment is very important. In our department, we performed thermoresotomy in 88 cases, microvascular decompression in 50 cases, with preference for the ballonic compression. We have no experience in glycerol injection and radiosurgery. We cannot talk about percutaneous technique without mentioning the name of Sweet, who performed for the first time in 1974 the thermocoagulation. The glycerol injection was introduced in 1974 by Hackinson. The radiosurgery was performed for the first time by Lexel in 1971. Addition to that, the ballonic compression was introduced as a treatment of the trigeminal neuralgia in 1984 by Mullen. We propose the thermoresotomy when there are failure of medical therapy, when the patient has major medical comorbidity, just like this young lady on the right who has gingival hypertrophy due to the DEDN treatment, when there is previous failure of microvascular decompression, when the pain is located in V2 or V2, V3, and finally, patient preference. The three landmarks of the heart health route, as he said, Professor Abdenbi early, identical for the different percutaneous approach. The first corresponding to location of the skin punctured 2.5 centimeter lateral to the edge. The second is on the inferior edge of the zygomatic edge, 3 centimeter onto the auditory canal. And the third is on the joining the first point to the pupil on the inferior edge of the orbit. The goal of the treatment is to have analgesia without anesthesia. However, hypoesthesia centered on the painful territory is necessary, and we almost hope to run a long study of a long data relief. This technique has a less significant morbidity. The result of the procedure were evaluated and categorized in excellent, totally pain-free, satisfactory improvement but coexistence with few pain episode and minor complication require small posology of carbamazepine, poor pain in daily life as talking or chewing associated to embarrassing complication as moderate or severe dysesthesia. Failure, same status than before the procedure. Percutaneous approach. First, thermoresotomy. The thermocoagulation technique requires a generator is clearly in this slide with a monitor of impedance, a monitor of temperature. He stimulates with a stopwatch that can automatically be turned off, a gauge 19 cannula, star, straight, or curve. This video sequence shows the material needed for the thermocoagulation. The introducer with his cannula, the thermistor, right for V2, and curved. Heart health approach, as you can see in this video, the introduction of the introducer is done from the first point. Professor Abdenbi, he detailed this technique. Is the same as ballonic compression, but in thermocoagulation is without general anesthesia, but under brief anesthesia. The progression towards the foramen oval is done through the CAN fluoroscope. And this is the good position of the thermistor. The thermocoagulation is made with a test stimulation for localized painful territory V1, V2, or V3 with 50 to 60 Hertz during 45 seconds in order to locate the selective painful territory. The stimulation test is followed by a lesion test, 60 degrees during 45 to 60 seconds, looking for unwanted side effects caused by the thermal lesion. This stimulation test is followed by definitive lesion at a temperature of 75 to 80 degrees, repeated until having the benefit effect of pain. This technique may encounter the impossibility of penetrating the foramen oval. Capablanca in 1995 had 11 cases. Then he reported them 2 weeks later. In our series, we had 22 cases. We had to propose to our patient other technique, microvascular decompression. Some other were helped by the TDM. In our department, Seratom, per-operative, or neuronavigation to cross the foramen oval. This image clearly shows the exact position of the thermistor at the triangular plexus when the thermocoagulation is performed with a good effect on pain. The literature review has shown that switch in 1987 work has a 99% success rate on pain with 37% recurrence rate. But as you can see, the work of our master, Professor Sendou, done in 2001, and Compolat had the best results with almost 99% of beneficial effect of pain and a recurrence rate close to 7%. Our results are similar to those of the literature with an immediate beneficial of pain in 98%. The second percutaneous technique is the glycerol injection. This technique that we are not familiar with and have no experience in performing this procedure. This is why we are going to describe it to you with the different steps. This technique is performed under general anesthesia, seated position head semi-flexed, goose 20, introducer essential, tank inoxol or metrazamide, 0.25 to 0.4 cc, volume of the trigeminal system. After repositioned downwards, injection of glycerol in the cavum mechalie, post-operative sitting position during 4 hours, to avoid glycerol lead inside the posterior fossa. Time required for action on the 5th nerve after diluted in the CCF and disappear. As you can see on this image, the glycerol on the trigeminal cistern on the left and the axial slice of CT on the right. Pollack percutaneous retrogastrian glycerol rhizotomy for patient with essential trigeminal neuralgia, a perspective analysis of factor related to pain relief, published in Journal of Neurosurgery. Kondoziolka in 2005 to publish an important series of 1,174 cases treated by glycerol injection, which show that some others use this technique massively. The study of the literature has shown that this technique is devoid of mortality. Atkinson, in a series of 75 cases, had an immediate relief of pain in 99%, but with a recurrence rate of 18%. Dekaman, in a series of 286 cases, had a relief of 95% and a recurrence rate of 13%. We believe that this technique presents the highest recurrence rate. Glycerol injection is made without stimulation, without cooperation, and with general anesthesia. Thermocoagulation is made with stimulation, with cooperation, and without general anesthesia. Action mode neurodestructive on trigeminal nerve, damage of pain fiber at delta and poorly myelinized C fiber within the branch of the trigeminal nerve. For the ballonic compression is the mechanical effect, for the thermocoagulation is thermal lesion, and for glycerol injection is chemical lesion. Some particularity of these two techniques, dysesthesia, are the prerogative of thermocoagulation as well as corneal complication. By account, hypoesthesia and early recurrence is more observed in the glycerol injection. In our department, we use thermocoagulation when the pain is located in V2, V3 or V2, V3 area, or patient or in bed status. When the patient has multiple sclerosis, thermoresotomy is more effective than our other percutaneous technique. A study carried by Taha and published in the Journal of Neurosurgery showed that the beneficial effect on pain is the same and is similar from one technique to another, but the recurrence is more important in glycerol injection. The same study also made by Taha concerning the complication of the different technique came out with classical conclusion, namely dysesthesia and corneal complication are the most observed complication in thermoresotomy. In modest comparative study that we made concerning the different technique to show the same conclusion already cited previously. The literature study of long-term outcome and the treatment of the trigeminal neuralgia performed by Kompolat and Professor Mark Sandhu. The long-term outcome efficacy of microvascular decompression and ballonic compression were similar, and their effect is superior to other modality. The recurrence rate was higher after thermocoagulation. The study suggests that each surgical technique for treatment of trigeminal neuralgia has merits and limitations. In conclusion, the results of the treatment for trigeminal neuralgia similar in the two techniques, except dysesthesia and keratitis more frequent in thermoresotomy and the recurrence appanage of glycerol injection. Merci pour votre attention.
Thank you, Professor Ghanan. And you will have, I think, some questions at the end. And now we call Professor Charles Valéry and Professor Philippe Cornu to talk about radiosurgery, and only to remember that Professor Charles Valéry is a senior neurosurgeon specialized in neuro-oncology and having a Master of Science in Molecular Biology. He is graduated from the University Louis Pasteur of Strasbourg and has performed his residency in Strasbourg and in Paris. Since 2010, the Gamma Knife Unit has treated about 7,000 cases in Pitié-Salpêtrière Hospital, including metastasis, neurinomas, meningiomas, vascular malformations, pediatric tumors, epilepsy, and trigeminal neuralgia, with a number of papers published. Dr. Valéry is also an associated member of Borelli Center, Paris-Saclay University, Professor Valerie, we call you. I think you will talk, or Professor Cornu?
Yes, just to mention, I would like to again congratulate all the precedent authors with their presentation, to thank, of course, all the staff of the Algerian Society of Neurosurgery, and thank for your kind invitation, and Professor Swat Bakhti, the president of the Society of Algerian Neurosurgery, also Professor Abdenbi, Benais Abdenbi, and reporting this very nice presentation about all this very huge experience. Professor also Lakhdar Genan, we thank you also for your kind words and the beautiful presentation you gave to us. And also Professor Tiglit, Nabila Tiglit, just to see her again and present on this webinar. We are going to present our radiosurgical experience, the experience of Paris, that will be reported by Professor Charles Valéry. So I will put the presentation on. Voilà.
Yes, thank you for your invitation. I'm very proud and happy of it. So we'll talk to you about radiosurgical management of trigeminal neuralgia. This is the summary of the presentation. So, as you probably know, the concept of radiosurgery has been expressed 60 years ago by Professor Lars Lexell.
Sorry, Professor Valéry, we don't have the slide.
I think it was in the wrong side of the mic. Okay. Do you hear me?
Yes, we hear you, but we don't have the slides.
Ah, you don't have the slides.
Yeah.
So I have to. Tu vas peut-être pas partager l'écran là. Il y a un truc qui marche pas. Non, oui, il faut repartir. Ok, ouais. C'est pas partagé là pour l'instant. Oui, oui. Et tu viens en arrière. Voilà. Now, tu fais un plein écran. Okay. Do you see now?
Do you see?
Yes,
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 okay,
yes,
okay.
we have the slide.
Thank you.
Okay, thank you.
As you probably know, the concept of radiosurgery has been expressed 60 years ago by Professor Lexell, Swedish neurosurgeon. It was to deliver a single high dose of irradiation administered with an extreme precision in a small volume inside the intact skull. You can see here the first prototype of gamma knife. So, interestingly, radiosurgery has been used for the first time to treat a trigeminal neuralgia in a female patient. You can see the photo here. This patient was improved by the treatment, but surprisingly, this technique has been used most widely just a few years ago, because I don't know exactly, we don't know why, but for 50 years, it has not been used for that indication. So it's commonly admitted that the radiobiological efficacy of this technique combines two effects: one immediate cellular acting on the cycle, and the other delayed acting on the microvascularization of benign tumors. In reality, we don't know exactly all the mechanisms involved in radiosurgery. There are probably other effects, basically possibly neuromodulation, working without destroying the structure of the system, nervous system, and producing an effect. Konciolka has worked on animal models and has showed that effect. So, a lot of clinical studies have been published about radiosurgery of trigeminal neuralgia, and three issues were studied: the delay of response to treatment, toxicity induced by the treatment, and then the sustainability of this response. The parameters influencing the occurrence were then analyzed. If the basic principle of the treatment of radiosurgery is to put a shot on the fifth nerve, number of nuances of the technique, choice of the target, choice of the dose, have thus been evaluated. One can say that it has been a long road between the first study by Konciolka in 1996 and the last report of Jean Régis, which came out in 2015. Schematically, after the initial gaser ganglion target, the root and tree zone has been chosen at the beginning by Douglas Konciolka. Then a more anterior retrogasserian target has been studied, particularly by Jean Régis. The choice of the root and tree zone is based on the anatomical and radiobiological reasons, because RES involve a transition between oligodendroglial cells that are radiosensitive and Schwann cells. Konciolka has tested an escalation of dose averaging 70 Gray with a fair efficacy, but limited durability of this response and acceptable rate of side effects. Other authors testing higher doses at the same location found unacceptable level of toxicity. On the left, you can see a study from Stanford with 74% reported numbness, and among them, 39% of severe ones. And on the right slide, a study from the Salles UCLA with 58% of numbness, and among them, 20% severe. This explains why other authors, in particular Jean Régis, try to define a target placed away from the brainstem, approximately 8 millimeters in the front of the brainstem, with average doses of 85 Gray, finding interesting results. Complete pain sedation rate of 91%, with the durability of this response of 65% at 5 years, and a pretty low morbidity, about 10% of bothersome dysesthesia. He found the existence of at least one previous surgery to be a negative prognostic factor for occurrence of pain sedation. Presence of hypoesthesia after radiosurgery and having less than 2 previous surgeries were positively predicting durability of pain sedation. The probability to develop a neuropathic toxicity was 20% in the same study, with a plateau after 4 years. Interestingly, the same team has shown that the speed of response to treatments, especially if it occurs within the first 48 hours, was associated with a lower risk of hypoesthesia after treatments. The Brussels team also tested an anterior retrogasserian target with a high efficiency with 83% response, recommending the choice of a target placed 5 to 8 millimeters in front of the emergence of the fifth nerve. Regardless the risk of toxicity related to the irradiation of the brainstem or the amount of the dose, there is a risk of toxicity relating to the length or volume of the nerve included in the treatment isodose. We call that the Flickinger effect. This effect was observed by Flickinger when he used not 1 but 2 shots to increase the volume of the fifth nerve covered by radiosurgery. This effect was also observed in the case of extended shots by blocking the beams, leading to an increased toxicity in patients treated by the Brussels team. In this case, a better pain outcome was observed, but the cost was a much worse rate of toxicity. The volume of nerve integrated in isodose could also have an influence on the durability of the response after gamma knife. Konciolka in this study has shown that the risk of recurrence after radiosurgery decreased as the maximum volume of the delivered dose applied to a smaller volume of the nerve. Finally, a recent published studies seems to show that regardless of the dose delivered, the dose rate could considerably modify the radiobiological effect of the treatment and thus influence the expected results. A low rate being associated with a decreased efficacy of the treatment. As you can see in this figure, the biologically equivalent dose increases with a shorter treatment time. What about the relationship between decompression surgery and the effectiveness of radiosurgery? Tualeska in this study showed that patients who had had a previous Janeta were less likely to have initial pain sedation, but had an unchanged risk of neuropathy and maintenance of sedation. In addition, patients with vascular nervous conflict did not have any difference regarding efficacy or toxicity of radiosurgery compared to others. In the particular case of multiple sclerosis, patients have a higher risk of recurrence than other patients, as you can see in this curve. In the case of second gamma knives, there are essentially an increased risk of hypoesthesia, as you can see here, compared to the first-line radiosurgery. Therefore, after considering results of literature, if we address the main issues of treatment of trigeminal neuralgia after gamma knife radiosurgery, parameters that might be associated with efficacy are dose to the brainstem, previous surgery and hypoesthesia. Related to toxicity are dose to the brainstem and Flickinger effects, and related to durability of response, hypoesthesia after treatment, integrated dose to brainstem, and previous surgery, and multiple sclerosis. Thank you. The technical nuances that might influence outcome of these issues in radiosurgery are choice of the target that should be anterior to brainstem and posterior to gastric ganglion, the dose that should not exceed 90, but should be at least of 80, and no use of plugging. At La Salpêtrière, we have treated around 500 patients for essential fifth neuralgia using gamma knife perfection and then ICON. We will focus on the population of 195 patients treated for essential neuralgia. The average follow-up is relatively short, 22 months. The average age of the patient was 69 years old. 6 of them presented with typical neuralgia from the first territory of the fifth, 64 the second, 47 the third, and 78 had more than one territory. These were neuralgia resistant to previous treatment. All of them had been already treated with drugs, a majority with Tegretol, but also Neurontin, Trileptal, Rivotril, Lyrica. 40% had had previous surgical treatment, 11 Janeta, 7 a balloon, 9 alcoholization, 66 thermorhizotomy, and 4 first gamma knife. The procedure used for the treatment is that of any cytotoxic procedure, fixation of the frame under local anesthesia in the operating room, then multimodality imaging with scanner and CT scan and MRI with several sequences, then dosimetry, and then treatment. After placing the frame under local anesthesia, a stereotactic imaging was performed. The target site was the retrogastrian region called plexus triangularis. Tolerance of brainstem was defined at less than 10 cube millimeter at 12 gray isodose and less than 1 cube millimeter at the 15 gray isodose. If full dose was not possible, we decreased the dose until 80 gray. Then we were plugging the shot to avoid the brainstem irradiation. This is the score we used, the Barrow Neurological Institute score for pain and for numbness. Results show that pain sedation rates was 93%, of which 62% were without medication. That was BNI 1 or 2. Median delay before pain relief was 52 days. Actual rates of pain relief at 3, 6, and 12 months was 73, 80, and 88% respectively. Using a multivariate analysis, previous surgery was a negative predictive variable. There was no influence of age or dose or existence of vascular conflict. Mean delay between gamma knife and side effects was 13.6 months. Actual rate of survival without side effects was 11% at 1 year and 21% at 3 years. 10 patients had bothersome or very bothersome side effects. Side effects were hypoesthesia in 21 cases, dysesthesia in 14 cases. No complete corneal anesthesia or anesthesia dolorosa was observed. Dose to brainstem was not correlated with occurrence of side effects, probably because we have a very homogeneous technique. Surprisingly, age less than 74 years old was predicting a better outcome in terms of side effects occurrence. Regarding the time between sedation and painful recurrence, 90% relapsed during the observation period, which is relatively short. The probability of maintaining sedation was 93% at 1 year and 78% at 5 years. Using a log-rank test, significant predictive parameters of maintenance of pain relief were previous surgery, you can see the curve on the left side, and occurrence of hypoesthesia on the right side. Follow-up was assessed by consultation at 1 month, 3 months, and then every year. Treatments after gamma knife failure were often drugs, but also surgery, thermoisotomy, a balloon, or a second gamma knife surgery, sorry. In conclusion, radiosurgery is currently the therapeutic approach which has the best efficacy-toxicity ratio in the treatment of drug-resistant trigeminal neuralgia. When it is realized second line after another surgical procedure, the efficacy is reduced, but side effects are not increased. The ratio efficacy-toxicity depends on 3 parameters: choice of target, dose, and length of the fifth nerve included in the treatment isodose. This is the algorithm we used in our institution. When it is the drug refractory neuralgia, when the compression is not indicated or feasible, the decision is made on based on the emergency of pain sedation. If a quick effect is required, excepting for the first branch of the fifth nerve, thermoisotomy should be preferred to gamma knife. In other cases, given its efficacy and relative harmlessness, radiosurgery is a therapeutic approach that can offer a first-line surgical technique with a good balance benefit-risk. As a perspective, I think that new imaging with tractography should offer us a way to monitor better the pain sedation and to then have a better therapeutic offer a better therapeutic strategy. Thank you very much for your attention. This is the team in La Salpêtrière. You can see here in the photo on the below right side, Professor Cornu and myself with Régis at Marseille. On the left part in Stockholm, the course and the first patient we treated in October 2010. And this is the team. Thank you very much for your attention.
Professor Charles Valéry, I thank you on behalf of all the speakers and all the attendees for this very interesting therapeutic modality. And we close the different possibilities Now, if there are questions from the assistants or from one speaker to the other speaker.
Professor Abdinbi, just to mention you that Professor Samaha has joined us, and Professor Samaha, we are very happy to have you with us. Really happy that you can join us. So,
how are you, Professor Samaha?
Microphone, Professor Samaha.
He has his phone off.
Yes. He was supposed to be with us today, but he had some troubles, but he finally could join us.
Good.
Microphone, please. No.
Professor, we can't hear you.
On voit son microphone off.
Okay.
Hello, you hear me?
Yes,
Yeah,
yes.
yeah.
Yes, yes. Today it is the first day I feel good after the corona for 3 weeks. So I'm happy and thank you very much. And I'm glad to see all of you directly, and thank you very much.
Thank you from Paris also.
Okay, good. Philippe, how are you? Good.
Good.
Nice to see you.
Nice to
Okay, Professor Sendou, good evening.
Yes, and good health for you.
Thank you very much, everybody. Thank you, everybody.
In a better state, Mohammed.
Sorry?
In a better state.
Yes, yes, thank you. Yeah, yeah.
Professor Abdinbi, do you want to begin by the questions of the audience, and after maybe there will be a discussion of the panel?
Yeah.
Well, actually, yes. My question for the radio surgery, that 10 years ago, we felt that when the gamma time was slow, we felt that the effect was better than the new uploading cobalt. But now the speaker says the reverse. Can he comment for that?
Yeah, there was a study comparing the effect on the trigeminal nerve when that was just new sources versus old ones, and it has been shown that it was more efficient when the sources were new. So that is in favor of what I said about the biological effects. So.
Yeah.
As the dose is the rate of the dose is increasing, I think the effect is better.
Yeah, okay, thank you.
Oh, okay.
Nabila, could you read the questions on the chat, please?
Yes, there are some questions. So the first one is how to manage recurrence of symptoms post microvascular decompression. Do you want me to?
I could not get the question.
Yeah. How to manage recurrence of symptoms post microvascular decompression?
Yes, very good question. Personally, I don't like to redo microvascular decompression after failure because we have alternatives. We have percutaneous lesioning, we have radiosurgery. And I think it can be dangerous to redo MVD, except if imaging show persistence of a huge compression. I'm not in favor of redoing MVD if properly done at first time. You have alternatives. You understand me?
I think yes. There is another question. So do you recommend or suggest any other product if Teflon is not available?
I try in the first stage of my experience, muscle, fat, aponeurosis, and this generated some fibrosis. If you cannot have a Teflon, I advise fat, not muscle, not aponeurosis.
Another question, I think also for you. Is a sling necessary or just placement of Teflon between vessel and fifth cranial nerve?
I'm not in favor of pushing a ball in between nerve and vessels. This is neocompression. I think we must not neocompress the nerve. So I use sling or some piece of rigid Teflon to maintain the artery apart. In some cases, we cannot, because of perforators, we cannot push away, and we can do interposition, but better transposition without anything to change the route. I demonstrated that. It was published in the American Journal of Neurosurgery, comparing two ways.
I think that Professor Youssef have a question. No, Nabila?
Yes.
Yes. Professor Youssef, please.
Is there some problem with the coagulating of the pontine transverse vein?
When the I try to avoid coagulating the superior petrosal venous system.
Okay.
Because this can generate hemorrhagic infarct or edema in the cerebellum and even sometimes in brainstem. But instead of avulsing the vein, you have done that time to time. I have avulsed the superior petrosal sinus at dura, and this is catastrophe. So better to coagulate and divide. For the transverse vein, which is generally rather small, I almost always coagulate and cut the deep transverse vein, but not the superficial superior venous system.
Okay, thank you.
Suad?
Monsieur Azhari?
Thank you, Suad. Thank you for and congratulations for Algerian Society for this outstanding webinar with very famous people for balloon as Abdenbi and for Professor Sandou, big series for the decompression, and for the Professor Valéry and la Pitié Salpêtrière for this in this pathology where they start gamma knife since many years. So I just have one question for Professor Sandou. We know that you are one of pillar of this surgery and one of pillar of SNCLF, la Société de Neurochirurgie de langue française. My question is, some neurosurgeons now start to do the decompression by endoscopy. What do you think about that?
I have no expertise in endoscopy, so I am inside to criticize because I'm not expert in that. But to be more serious, those who do endoscopy for MVD, for trigeminal neuralgia, turn a bigger hole to put the endoscope and to introduce the instruments outside the endoscope. So this is not real endoscopic surgery. For trigeminal neuralgia, I think we don't need to go in the corner. You can see through the microscope. And but I must say that this gives better image. This is for publication. For hemifascial spasm, maybe endoscopic to go in the corner can be useful, but not for trigeminal neuralgia. I'm not sure to be right, but you ask me a question, I honestly answer.
One of our colleagues in Morocco, in Marrakesh, is Professor Aniba, who is has very good experience in endoscopy, in general endoscopy, and he present us in the monthly séance we do with Moroccan Society is les assises de neurochirurgie. Every month we do that. So he showed us some cases. He did it with endoscopy, and it seems very nice. The image and everything is big. You know, that is perhaps people they are going to this technique with the development of the endoscope. Now you know that the endoscope are changing, and now there is 4Q and more than HD endoscope. So perhaps in the future, with the people who are very interesting by endoscopy, you know that young neurosurgeons are very interesting by endoscopy. Perhaps they will develop some things like you developed with the microsurgery, Professor Sand.
I think you are right, but I want to be a little critical. This is not endoscopic surgery. This is microsurgery assisted with endoscopy. And it is true that it is fun for young people need fun. And second, this gives a very nice images for publication. And as a senior neurosurgeon, we must react on that. I agree. We cannot escape that, but honestly, it's more microsurgery than endoscopy for trigeminal neuralgia. Of course, for tumors, intraventricular tumors, it's the way.
Thank you, Monsieur Sandou.
Anyway, Professor Lazare, thank you for being here. Thank you again.
Professeur Abdenbi? Je crois qu'il a un petit problème de connexion.
Can you hear me, Dr. Sindou?
Yes, yes.
Yeah. I would like to congratulate the Algerian team for their very nice work in trigeminal neuralgia and functional, and mainly they developed balloon compression surgery, which is very respectful for the nerve, very little complication with balloon compression. And I want to acknowledge that.
I would like also to have a comment on this and to the team using this technique in Algeria. I think that Professor Genan mentioned it, as also Professor Abdenbi. Are you trying to find, I should say, more refined technique to have, you know, a more quantitative evaluation of what is being done during balloon compression, either duration, either pressure of inflation of the balloon, and of course, according to the outcome of these patients, and also through navigation approach in order to avoid different difficulties that we have mentioned, both of you, Professor Abdenbi, and you, Professor Genan.
Thank you, Professor Cornu. You know, step by step, we reach this characteristic of the balloon concerning the volume and the duration. And in the first paper published in 1995, we wrote about the 50 first patients, and with an inflation and a duration different from this of today. But really, and think me, with this, the approach of today, 0.7 cc of contrast medium and the duration of 6 minutes, we avoid many of the side effects, many of the complications, and we are satisfied. More that we think we are surprised by the small duration, the small inflation in some series. The mind, we will not change it tomorrow, and we will persist in this way.
Okay, thank you very much for your response.
Shall I ask a question? Hello, thank you everybody.
Please, who is talking now?
Professor Lakhdar, Professor Lakhdar.
From
Oui, professeur Lakhdar, on ne voit pas, c'est pour ça.
Je veux poser une question pour professeur Sandou pour lui dire.
Là,
If you can explain.
In English, and please.
I want to ask Professor
Gunnen. Professor Gunnen. First,
yes.
Before you, there was two persons, I think, Professor Lakhdar and Dr. Abdullah Zaidan, I think. And after you can, thank you.
No problem. No problem. Okay.
Dr. Lakhdar, Professor Lakhdar, please.
Thank you for this nice webinar, and thank you for these very interesting talks. Congratulate the Algerian Society of Neurosurgery for organizing a webinar about this very interesting topic. My question is about the percutaneous technique and the use of X-rays. I think some teams use now the neural navigation to avoid the radiation. What do you think? Professor Sandou, Professor Abdelnoui, and Professor La.
Professor Sandou, you start, yeah?
I was trained a long time ago in Boston by Bill Sweet himself, and I became quite skilled with only X-ray. I have done 4,200 patients with thermoresotomy for elder patients. I did not use the neuronavigation, but if I would be younger, I would start with neuronavigation.
Just a comment. I think that, of course, when, as says Professor Sandou, when you have a huge experience like also Professor Abdelnoui or Professor Guénan, it's different. But I think for young neurosurgeon, it may help, at least in the beginning, to reduce the time of, the progression in the technique and to reduce the curve of the learning curve.
The first neurosurgeons, as Jean Siegfried, Sweet, and also among us, with us, Professor Sandou, with a series of a number of thousands of patients with X-rays, mean that it is possible, because we don't emphasize or focus essentially on the difficulty to cross the foramen ovale, maybe 2 to 3%, and when you redo the surgery some days after, it's possible to cross. I think it isn't a blind surgery, because for a young neurosurgeon with this skin puncture, and you tell him we will go to the gaster ganglion inside the skull, it's like mirage. Je ne sais pas comment on va dire le. I think neuronavigation, especially in small cases, and usually the surgery takes around 3/4 of an hour to 1 hour.
Thank you. Thank you.
Professor Abdullah Zaidan.
First thing, good evening for everybody, especially for Dr. Suad who organized this meeting. I'm really very honored and happy to see my teacher, Professor Sandhu. I don't know if he remembers me or not. I was his student 22 years back in Lyon. Monsieur Sandhu, je suis très heureux, je suis très honoré de vous voir encore. Professor Abdelnabi, you are a teacher for us in the Pan-Arab region, and I think that you remember me. We met maybe 15 or 20 years back with Dr. Minyawi and Dr. Khalaf al-Mutairi and the others, if you remember. I'm really honored and happy today to be with my teachers and all the fellows. I'm also honored to hear from Professor Cornu and Professor Valerie and also Dr. Ginan. It was really fruitful meeting today. I have plenty of questions. I don't know if I'm allowed to ask one or two of them. I'm really happy today seeing also Dr. Samaha, who is a country mate, and he's a friend of me since maybe 20 years. We didn't meet also, and we are meeting today. I'm really very happy to meet all of you. Can I ask maybe some questions? I try to be short. First question to my professor, Sandhu. When I was with you, we had always, or maybe frequently, some problems of CSF leakage from the cases of the neurovascular decompression. After your long experience, what are your advices to minimize the percentage of the CSF leakage which you was having?
Thank you. First of all, I remember you.
Thank you.
I remember you. Thank you. Yes, to avoid CSF leakage, which was a large number of cases at beginning, I used to harvest fat and to close the dura with aponeurosis and fat. And by using that, packing fat in the craniotomy, no more CSF leakage.
We was not using this technique before in the 90s, if I remember properly. But with the fat, do you think now it's much less than before?
Yes, almost none.
Almost none.
I harvest fat on the thigh, which in addition is 10 minutes more. But this avoids CSF leakage. You are right. Thank you for your question.
Thank you, Professor. Well, my second question to Dr. Abdelnabi. When you are not able to introduce your catheter or cannula in the foramen ovale due to the either anatomical variations or hypercalcifications, what are the solutions you are trying to go to find treatment for HP?
Believe me, we redo the surgery some days after, and it seems, and really, it is possible in 80% to cross the foramen ovale. Sometimes the metallic introducer for the balloon compression is more thick than the introducer for the thermocoagulation. So when it is impossible to do the balloon compression, the thermocoagulation can be a solution also. But generally in 80% with the same neurosurgical approach, we resolve the difficulty.
I'm sorry if I understood.
Another thing, when you are two around the patient till 1 year or till 1 year ago, Professor Gannan every time call me when he has trigeminal neuralgia to operate and vice versa. When you are two and one is not able to perform, the other is here to do that.
Okay, but what about in cases where there is a long spine, as you said, or a very narrowed or calcified foramen ovale? I mean, you said 80% of cases you are able to, but what about the other 20%? What we can do for them?
You can do thermocoagulation with
thermocoagulation also will have to go inside the foramen ovale.
Naam, yes.
Je dis, on est obligé de passer dans le foramen ovale pour passer pour faire la thermocoagulation aussi, non?
I said that the introducer for the thermocoagulation is thinner than the metallic introducer for the balloon compression.
Okay.
And you can pass.
In 100% of cases?
Yeah, it's easier.
Thank you anyway. Thank you, I'm very honored. Thank you very much, Dr. Saad, for giving me the chance for talking. Thank you very much.
Gnen, I think it's for you now. Microphone, please. Gnen, microphone, yes, okay.
Yes, okay. Yeah. Professor Sandhu, why trigeminal neuralgia after multiple sclerosis respond better to thermocoagulation?
Yes. Trigeminal neuralgia due
another technique.
Yes. I don't believe in MVD for multiple sclerosis. I don't believe it can work. The neurovascular conflict, even if there is an image on the nerve in patients with multiple sclerosis, I don't use MVD. I have done in a few patients. This fail all the time. Second, balloon compression does not give strong hypoesthesia. This is why there are many recurrence. Thermocoagulation, if you don't do with intense current, there is recurrence. If you do with intense current, with hypoesthesia, less recurrence. This is because with thermocoagulation, you can create a strong hypoesthesia. This is why the effect is stronger. Radiosurgery, I don't know. You can ask Professor Valéry. Professor Valéry will speak about that. We answer you.
The radiosurgery is less effective, of course, in multiple sclerosis. It's I think 20% less efficiency with multiple sclerosis than when it's essential to trigeminal neuralgia. So I think it's not really a very good solution. But
okay. Thank you.
Excuse me, Dr. Sindhu speaking. Thermoresistance is effective if you create strong hypoesthesia. You know that. Complication is anesthesia, corneal anesthesia. If you use stimulation with not 50 cycles per second, but 5 cycles per second, you can see so-called blink reflex. You stimulate the root, you create orbitocularis contraction, which is named blink reflex. If you have blink reflex under stimulation with a low intensity, that means that you are in the corneal fibers. You have to withdraw your electrode a little bit to see blink reflex disappearing, and then you can create coagulation with strong hypoesthesia without corneal reflex. I'm not sure to be clear. It's important. You can avoid corneal fibers by stimulating 5 cycles per second. Check the blink reflex. If there is a blink reflex, orbito-ocularis stimulation, you withdraw or modify location of your electrode. This is to decrease complication.
Another questions?
No.
Please, shall I ask a question to Professor Sandhu about when you say hypoesthesia after thermorhizotomy, is it permanent hypoesthesia or like balloon compression, transient hypoesthesia?
Generally, it's a strong, immediate hypoesthesia, and sensory function can improve, and on long run, you have still hypoesthesia, but less important, but still hypoesthesia. Hypoesthesia, no recurrence, no hypoesthesia, recurrence.
But it's the same in balloon compression also. This is the same reasoning. It's when we obtain hypoesthesia, it's efficient.
Yes, same with balloon, but balloon is less aggressive than thermorhizotomy. If you use thermorhizotomy with low thermal lesion,
okay,
not much hypoesthesia. If you use strong thermal lesion, hypoesthesia.
Okay, thank you.
You must ask the patient, what do you prefer, to have higher rate of recurrence and low hypoesthesia, or you accept hypoesthesia and you will not have recurrence? You have to contract that with the patient. In elder patients, I don't like to have recurrence because they are fragile, and I prefer to have hypoesthesia in elder patients, provided escaping the corneal fibers. By the way, I explained to you. Check the blink reflex with 5 cycles per second. And if you have blink reflex with low intensity during stimulation, you are in fibers of cornea, and you have to modify position of your electrode under X-ray control.
Maybe, Professor Sandhu, the difference is in the hypoesthesia or anesthesia added to anesthesia dolorosa in thermocoagulation, what we don't observe in balloon compression. Anesthesia dolorosa or dysesthesia, severe dysesthesia, are rare, exceptional. That is not the case in thermocoagulation.
I totally agree with you. Balloon compression, not much hypoesthesia. So very few cases of anesthesia dolorosa. Thermorhizotomy, if you use short thermolesion, not high intensity, very little hypoesthesia, no anesthesia dolorosa. But if you use thermorhizotomy with strong hypoesthesia, you will get anesthesia dolorosa.
Please, if there is no other question, shall I ask a question for Professor Abdelnabi and Professor Lakhdar? When we do balloon compression, even we do the same thing for all the patients. Not all the patients are the same results in regarding hypoesthesia. Some patients have very transient hypoesthesia for some days or weeks, and others for 1 year or more. So is it the anatomy of the cistern? What are the factors that make the degree that determines the degree of hypoesthesia obtained after balloon compression?
The Professor Lakhdar, we think about this since a long time, why some patients have this hypoesthesia for long months and other for a few weeks. you know, it's in relation maybe with the shape of the balloon. When you have a balloon which is not pear-shaped, the pear shape is the shape of the gastric ganglion and the triangular plexus. Exactly. When you have a circular balloon, it is not, il n'est pas circonscrit à la configuration de l'anatomie. Donc, the consequence is a slight hypoesthesia or hypoesthesia for some weeks. And the corollary is the recurrence. The same thing for the thermocoagulation. When you have a slight hypoesthesia or hypoesthesia for some weeks, maybe the recurrence will happen in some months or 1 year or 2 years. When the hypoesthesia is here for 1 year or more, the recurrence is absent or not happen. Maybe for the answer, maybe in relation with the configuration of the anatomy of the gastric ganglion and the shape of the balloon.
Okay, thank you.
May I make some comments? Pear shape mean you are inside the Meckel cave. Not pear shape, you are outside the Meckel cave.
Okay, thank you.
Professor Abdel,
maybe also we talk about the CSF leak or CSF leakage, maybe with the opening of the dura, it's easy for the balloon to be really inside the Meckelli cave, Meckelli cave. Professor Barti.
Yes, Professor Abdenbi, I'm afraid that the discussion was very, very interesting and the webinar also very interesting, but it is time, I think, to finish, and maybe you will give a few words before I make the conclusion.
Saad, je peux donner une information au nom de la SNCLF ou je laisse Monsieur le Président la faire pour la RAP?
Between you see you and Philippe. You
are Philippe, the president first.
Maybe we will close the webinar and after the informations and the word of our president.
I would like to thank you.
I was and I am very, very happy and enjoyed to be with all of you, especially Professor Marc Sandou. He's not here.
Yes, I am here.
Vous êtes là, Professor Marc Sandou, more than a friend, brother. I know him since now 40 years. And I know that my coming to Lyon has opened the door for many Algerian neurosurgeons. And I wish you long life, many works again, enjoyed also by your meeting, all of you. Professor Berti, our president, I thank you. And I tell you good evening and see you soon, inshallah.
Inshallah. So, Philippe, you can give, please, information about French-speaking society, because today we are in collaboration with the WFNS, and as many knows that many people who are in this webinar are members of this society. So it will be fruitful to have information.
So I would like first to congratulate the Algerian Society of Neurosurgery for this wonderful webinar, for inviting us and being again all together this afternoon with a very real pleasure. For the French-speaking society, you want me to speak in French or to speak in English?
No, because we have people who are speaking.
Okay, I will. So
in English, please.
We will not have a congress for the French-speaking society. We will have a webinar. This webinar will be probably held on the 12th of Saturday, 12th of December, on a long afternoon in between 2 p.m. to 8 p.m. with the different presentation. My hope is to be all together for this afternoon, gathered with pleasure and exchanging important informations around the world of our colleague in their own country, news from their health, news of their innovations, and you will receive from me very soon the announce of this webinar and also its program.
Thank you, Philippe.
Thank you for being all together just for one afternoon, but very, very warmly.
Thank you, Philippe. So thank you in the name of the Algerian Society. Thank you to the speakers with their outstanding presentation. Thank you, Philippe and Professor Sandou, for accepting to join the WFNS Committee of Radiosurgery and Functional Surgery. And I just want to have special thanks to Professor Samaha, with all my best wishes of health for you. And it was a pleasure to see you with us today. So thank you to everybody, and see you next webinar of the Algerian Society of Neurosurgery.
See you.
Thank you.
Right.
Thank you. Good evening.
You.
Thank you.